Our mission today is to provide you with a full, integrated understanding of this central command post.
Right.
We're going from the bony cage designed for defense all the way to the incredibly delicate neural and vascular networks that run its systems. We're going, far beyond the textbook definitions today.
And that level of detail is absolutely warranted, because the thorax isn't just a cavity, it's the entire upper part of the trunk, and it houses life itself.
Life itself. That's a good way to put it.
We're talking about the heart, the lungs, the major vessels, the esophagus, the trachea, and the complex, integrated nervous and lymphatic systems that manage everything from blood pressure to respiration.
It's all in there.
It's all packed in.
Yeah.
So understanding this region is foundational because it operates in two critical modes at the same time. First, as a rigid protective framework, and second, as this sophisticated mechanical engine for breathing and a central highway for nearly all communication nerves and vessels between the head, neck, and the entire abdomen.
Okay, let's unpack this mission.
Mm-hmm.
Our sources consistently emphasize that dual identity. You have protection via the bony cage and a connection via the major openings and all the internal conduits.
Right. The framework protects the vulnerable viscera, the organs.
While the openings, the superior and inferior apertures, they facilitate that critical connection with the neck above and the abdomen below.
Exactly.
So what we're going to do is systematically dismantle the thorax, look at its component parts, and then put it all back together again for you.
Sounds like a plan.
We'll start with the musculoskeletal foundation and the mechanics of movement, then move into the fascinating internal organization of membranes and compartments, tackle the complex vascular and lymphatic networks.
The highways, basically.
The highways, yes. And finally, we'll look at how this dense internal architecture maps onto the surface of the body, which is the absolute bread and butter of clinical practice.
It really is.
Starting right at the foundation, we need to talk about the physical structure, the bony cage itself. When you look at it, it truly is a masterpiece of biological engineering.
It is.
It manages these paradoxical needs of being rigid enough for protection, but, flexible enough for movement.
Mm-hmm.
What are the core components that define this structure?
Well, the detailed composition is incredibly precise, and it involves three primary sets of bones. Posteriorly, so on the back, we have the 12 thoracic vertebrae. We call them T1 through T12.
Okay.
Laterally, on the sides, we have 12 pairs of ribs, along with their associated costal cartilages, which we'll get into.
Right, the cartilage is key.
It's essential. And then anteriorly at the front, we have the sternum. Together, they form what is structurally described as an irregular, truncated cone.
The cone shape is important, right? It's not just a straight cylinder or a barrel.
Exactly. It's an irregular cone. When you look at its cross-section, it's slightly convex. It bulges out anteriorly and laterally. And this shape, combined with the way the ribs attach obliquely, sort of slanting downwards, provides the maximum structural integrity to deflect external blows.
So it can take a hit?
It can take a hit while still allowing the necessary elasticity and volume change required for continuous cyclical respiration. It's a perfect compromise between kinetic function and static defense.
Let's look closer at the ribs then. They're really the defining feature. We have 12 pairs, but our sources detail a specific classification system based entirely on their connection or lack of connection to the sternum.
And that classification is key because it reflects their functional role in respiratory mechanics. The ribs don't articulate directly with the sternum. They use these extensions made of hyaline cartilage called costal cartilages.
And that's what provides the crucial elasticity for volume expansion.
That's the spring in the system.
Sure.
So we start with the true ribs. These are the first through the seventh pair.
Okay, true ribs. Why?
They are true because each one connects directly to the sternum via its own individual costal cartilage. They are the most structurally important for the anterior stability of the chest. They form that solid front.
I see.
Next, we have the false ribs, typically the 8th, 9th, and usually the 10th pair. They articulate indirectly.
So they don't get their own connection?
No, their costal cartilages connect to the cartilage immediately superior to them. They're essentially hitching a ride up the line until they meet the 7th cartilage. It's like a cascade.
A cartilaginous chain.
A cartilaginous chain, exactly. And finally, the floating ribs, the 11th and 12th pair, and sometimes the 10th can be one as well.
And these are the most flexible?
The most flexible and perhaps the most distinctive because they do not connect to the sternum or to any costal cartilage above them at all. They terminate in the posterior abdominal wall musculature.
That makes perfect sense from a kinetic standpoint, doesn't it?
Mm-hmm.
The lower you go, the more movement you need for the diaphragm and the organs below.
Precisely. It allows for that massive diaphragmatic excursion.
Speaking of movement, the joints formed by those cartilages, the sternocostal joints, they're not all the same. That difference between the first rib and the others is structurally fascinating.
It is absolutely fundamental. When the costal cartilages articulate with the sternum, the joint formed by the first rib is unique. It's usually a synarthrodile joint.
Which means it's immovable or very slightly movable.
Exactly. And this stability is critical. It essentially fixes the top of the sternum, the manubrium, and provides a stable base for the superior thoracic aperture.
The thoracic inlet.
Yes, which is just crowded with major vessels that cannot tolerate excess movement. You can't have the blood supply to your brain jostling around.
Right. So what are the others, ribs 2 through 7?
The rest, from the second to the seventh, are synovial joints. These are crucial because they permit the essential gliding and slight movement necessary for what we call the pump handle and bucket handle mechanics of respiration.
We will definitely be diving into that.
Oh, yes. And just to complete the picture, posteriorly, all the ribs articulate with the vertebral column via costovertebral joints. And these involve specific superior and inferior articular facets on the rib heads, fitting precisely into corresponding facets on the vertebrae. It's like a lock and key.
So stability up high, flexibility down low. That's the design philosophy.
That's it in a nutshell.
Now let's turn our attention to the pathways, the major openings or apertures that link the thorax to the neck and the abdomen.
We have two key openings, superior and inferior. Starting at the top, we have the superior-thoracic aperture, which is commonly and clinically referred to as the thoracic inlet.
Okay, and its boundaries are very specific.
Highly precise. It's the superior border of the manubrium at the front, the medial borders of the first ribs on the sides, and the body of the first thoracic vertebra, T1, at the back.
It sounds like a narrow choke point. And considering it's where all the great vessels and nerves pass through, that sounds potentially problematic.
It is relatively small and very, very dense. Our sources highlight its critical dimensions. It's approximately 5 centimeters from front to back and about 10 centimeters across.
Not a lot of wiggle room.
Not at all. But more critical than the size is the geometry. The superior aperture isn't flat. It has a significant oblique angle sloping steeply down and forward.
Antero-inferiorly.
Correct. And this oblique angle, combined with the presence of the rigid first ribs and the clavicle sitting just above, makes it a critical gateway.
And clinically, this tight space is why we hear about conditions like thoracic inlet, or more commonly, thoracic outlet syndrome.
Precisely. This gateway is where the major vessels, like the subclavian arteries and veins, the brachial plexus, that huge nerve bundle for the arm, the trachea, and the esophagus, all have to transition between the neck and the chest.
So it's a bottleneck.
It's a major bottleneck. Because the first rib is fixed and the space is so tight, any clinical issue like having an extra rib, a cervical rib, or, say, abnormal muscular hypertrophy, or even a tumor at the apex of the lung can impinge on these structures.
And that leads to the symptoms.
It leads to vascular or neurological symptoms in the upper limb, which is the very definition of thoracic outlet syndrome. The superior aperture is where the functional anatomy of the neck and chest collide. It's a high-rent district, anatomically speaking.
Moving to the opposite end, we have the much larger inferior thoracic aperture, sometimes informally called the thoracic outlet, though, as you said, that term can be confused with the inlet syndrome.
Yeah, the terminology can be a bit tricky, but its boundaries are far more extensive. They form the entire base of the chest cavity.
So what defines this larger opening?
Posteriorly, it's defined by the body of the T12 vertebra. Posterolaterally, by the 11th and 12th ribs.
Our floating ribs again?
Our floaters.
Yeah.
And anteriorly by the continuous costal margins, which are formed by the fused cartilages of the 7th through the 10th ribs. And it's all capped by the xiphisternal joint, which sits roughly at the T9-T10 vertebral level.
So it's vastly larger than the superior aperture.
Immensely larger, and it lies nearly horizontally. And as we noted, confirming that cone shape of the thorax, its diameter is smallest at the back and largest at the front and sides.
And its great significance is that, unlike the superior opening, which is this busy highway, this opening is effectively sealed.
Exactly. Its massive opening is almost entirely closed off and occupied by the primary engine of breathing, the respiratory diaphragm. And this turns the inferior aperture from just a simple opening into a functional floor and a critical separator between the thoracic and abdominal cavities. This is absolutely crucial for maintaining the negative pressure within the chest that's needed for breathing.
Let's focus on that anterior structure that links the two sides together.
Yeah.
The sternum, or breastbone, It has 3 distinct, recognizable parts.
It does. The sternum is composed of the manubrium superiorly. You can think of that as the handle.
A handle, I like that.
Then you have the elongated body centrally and the small xiphoid process inferiorly, which means sword tip.
Manubrium, body, xiphoid.
Correct. The manubrium is where the clavicles articulate, the sternoclavicular joints, which offer the only bony articulation between the entire upper limb and the axial skeleton. It also has attachment points for the first 2 costal cartilages.
And the joints connecting these sternal parts are, again, absolutely critical anatomical landmarks. You can feel them on your own chest.
We use them constantly in clinical exams. We focus on the manubriosternal joint, which forms that palpable transverse ridge called the sternal angle, or the angle of Louis.
And that joint articulates precisely at the level of the second costal cartilage.
Yes, which makes it the perfect place to start counting ribs. Inferiorly, the body joins the xiphoid process at the xiphosternal joint.
Here is the central organizing concept of the entire thorax, something our listener really needs to grasp fully. The sternal angle is not just an anterior ridge you can feel, it defines a critical internal plane.
This is where it all comes together. The manubriosternal joint marks the highly significant transverse plane of the thorax.
An imaginary line.
An imaginary horizontal plane that divides the entire thoracic cavity. It runs from that joint precisely between the lower part of the T4 vertebral body and the upper part of the T5 vertebral body at the back.
T4, T5.
That's the level. This simple, palpable ridge provides the gold standard reference point for dividing the superior and inferior mediastinum.
The central compartment.
Yes, but more importantly, it marks a location of several critical events. It's where the trachea bifurcates, where the aortic arch begins and ends, and where the superior vena cava drains into the heart. It effectively slices the functional anatomy of the thorax in half internally.
We've established the rigid container and this central organizing line. Now let's talk about the engine that moves it, the muscles. We can categorize them as intrinsic, the deep chest wall muscles, and extrinsic.
Right. The intrinsic muscles are the workhorses of the chest wall itself. They span the intercostal spaces between the ribs.
So they're subtle but vital.
Absolutely. They're vital for positioning and stabilizing the ribs during the breathing cycle. The main players are the 3 layers of intercostal muscles: the external intercostals, the internal intercostals, and the innermost intercostals.
3 layers.
3 layers. They run in the intercostal spaces, and their fibers run in different directions, almost like the plies of a tire. This provides both strength and flexibility, and it acts like a scaffold that maintains the intercostal space during the rapid pressure changes of breathing.
And the extrinsic muscles. I understand their primary role isn't breathing, but their attachment points are still crucial.
They are primarily locomotor and postural muscles, things like the pectoralis major and minor, serratus anterior, and the scalens in the neck.
So they move the arms and support the head.
Correct. They attach to the chest wall, but they're mainly involved in movements of the upper limbs or spinal posture. Their attachment points really demonstrate how the thorax functions as the central anchor for the entire upper body kinetic chain.
But they can help with breathing, can't they?
They can. When breathing becomes strained, say during strenuous exercise or in respiratory distress, these extrinsic muscles, which are normally used for limb movement, can be recruited as accessory muscles of respiration to elevate the chest cage even further.
You see that in patients who are struggling to breathe, they'll often brace their arms on something.
Exactly, to fix the shoulder girdle so that those muscles can pull up on the rib cage. It's a classic clinical sign.
Now let's deep dive into the actual mechanics of how the cage moves. Our sources confirm this isn't just a simple expansion and contraction. It involves 2 specific coordinated movements based on how the ribs are hinged at the back.
This is a perfect example of biomechanical brilliance. The rotation of the ribs relies on those synovial joints we mentioned earlier. We talk about the pump handle movement and the bucket handle movement.
Okay, let's break those down. Pump handle first.
The pump handle movement primarily affects the upper ribs, say the 1st to the 6th. Since the heads of these ribs articulate lower down on the vertebrae, their sternal ends move upward and forward when the intercostals and diaphragm contract.
Like lifting the handle of an old-fashioned water pump.
Exactly like that. This movement increases the anteroposterior AP diameter of the thorax, the front to back dimension. It accounts for a significant portion of the total volume change.
And the bucket handle movement handles the width.
Precisely. The bucket handle movement is predominantly seen in the lower ribs, the 7th to 10th. Their articulation causes them to swing upward and outward when they're elevated.
Like the handle of a bucket being lifted from the side?
Just like a bucket handle. This movement is responsible for increasing the transverse or side-to-side diameter of the thorax.
Well, you have both happening at once.
Yes, the combination of these two movements, increasing the front-to-back dimension and the side-to-side dimension, maximizes the volume increase inside the chest and is absolutely crucial for efficient ventilation.
So the centrothroidal first joint ensures stability for the inlet, while the synovial joints below enable these complex pump handle and bucket handle movements. It's an incredibly elegant system.
It truly is.
Now we come to the primary driver of it all, the diaphragm, sealing that massive inferior aperture.
The diaphragm is a complex musculotendinous sheet, and its anatomy is crucial for understanding its power. Its attachment points are incredibly wide-ranging, forming the full circumference of the inferior thoracic aperture.
So where does it attach?
It attaches anteriorly to the lower 6 costal cartilages and the xiphoid process. And posteriorly, it attaches to the lumbar vertebrae via the crura.
The crura, these are musculotendinous extensions, right?
They are. And laterally, it anchors using the medial and lateral arcuate ligaments, which are thickenings of fascia over the muscles of the posterior abdominal wall.
The crura are particularly significant, aren't they? They're the main link between the diaphragm and the spine.
They are vital. The crura are these fibrous arches that anchor the diaphragm to the anterior aspect of the lumbar vertebrae, usually L1 to L3, with the right crust being longer and attaching lower than the left.
And they do more than just anchor it.
Much more. They also form muscular rings or slings around the openings for the esophagus and the aorta. This ensures that as the diaphragm contracts and moves, these major vertical structures are stabilized and not excessively pinched or compressed. They are the true posterior anchoring system.
And its shape is that famous dome.
Correct. When it's relaxed, it is highly domed. And the right dome sits noticeably higher than the left.
Why is that?
That anatomical asymmetry is a direct consequence of the large mass of the liver sitting just underneath it, pushing the right side superiorly.
So it's literally making room for the liver.
It is. Then, when the diaphragm contracts, that dome flattens, pushing down on the abdominal viscera and simultaneously increasing the vertical dimension of the thoracic cavity, which is what draws air into the lungs.
The source material provides some fascinating data on the sheer range of movement of this muscle, which really speaks to its importance.
It really highlights the power and efficiency of this single muscle. During quiet, normal breathing, the vertical excursion of the diaphragm is minimal, maybe only 1 centimeter or so. That's all for quiet breathing. But during deep forced respiration, like when you're exercising or taking a deep breath for a test, the excursion increases dramatically. It often ranges from 7 to 10 centimeters.
That's a huge difference.
It's massive, and that maximal excursion is necessary to achieve full inspiratory capacity.
Yeah.
It really reinforces why the diaphragm is quantitatively the single most important muscle of respiration.
So we've established the flexible protective exterior. What happens once we look past the bone and muscle and see the internal organization? The structures inside are protected by this elaborate layering system, starting with the connective tissue, or fascia.
The primary layer lining the interior of the cage is the endothoracic fascia. This is a specialized layer of loose connective and fibrous tissue that lines the inner surface of the thoracic wall. It sits directly external to the parietal pleura.
Okay, so it's a lining. But why should our listener care about this specific layer of connective tissue?
Its clinical significance is profound because of its continuity.
Its continuity.
The endothoracic fascia is not an isolated layer. It directly connects superiorly with the deep fascia of the neck and, crucially, inferiorly with the fascia of the abdomen, specifically the extraperitoneal fascia and the retroperitoneum.
And how does it make that connection?
This connection happens particularly where structures like the aorta, the inferior vena cava, and the esophagus pass through the diaphragm via their respective hiatuses or openings.
So if a severe infection or a fluid collection develops in the retroperitoneum in the abdomen, say a perforated appendix or a kidney abscess, it could track superiorly through this plane.
Absolutely. That continuity means this fascial plane acts as a direct pathway, almost like a subterranean tunnel, for the spread of infections, inflammatory fluids, or even bleeding.
Wow.
It allows pathology to migrate easily between the abdomen, the chest cavity, and sometimes even all the way up into the neck. This understanding is key for emergency medicine and surgical planning. You have to know where things can spread.
Moving past the endothoracic fascia, we reach the pleural cavities and the membranes that envelop the lungs.
Right. The lungs sit within the left and right pleural cavities, which are completely separate, airtight compartments. Each cavity is lined by two continuous serous membranes, the parietal pleura and the visceral pleura.
Let's clarify the functional and clinical difference between those two membranes for everyone.
The parietal pleura lines the periphery of the cavity, the inner surface of the thoracic wall, the mediastinum, and the superior surface of the diaphragm.
And critically, it's sensitive to pain.
Highly sensitive to pain, because the parietal layer receives general somatic innervation from the intercostal nerves and the phrenic nerve. So inflammation or irritation here, pleuritis, is excruciatingly painful.
And the visceral pleura.
The visceral pleura, conversely, covers the outer surface of the lung itself. It's shrink-wrapped onto the lung. And since it receives only autonomic innervation, it is entirely insensitive to pain.
That's a huge distinction.
It's a critical one. And in between these two layers is a thin, lubricating film of serous pleural fluid, which allows the lungs to expand and contract frictionlessly against the chest wall.
The lungs don't fully occupy these cavities, which brings us to the pleural recesses. I find this concept of reserve space fascinating.
They are vital potential spaces. The recesses are parts of the pleural cavity that the lungs do not fill, even during maximal expiration. They act as essential reserve spaces that are only filled when maximum respiratory effort is required.
So there's always a little extra room.
There is. And the most significant and largest is the custodia phlegmatic recess. This is the deep space located between the costal pleura, which lines the ribs, and the diaphragmatic pleura. It's a sharp gutter at the bottom of the cavity.
And the significance of the custodia phlegmatic recess, clinically speaking.
It creates a crucial safety margin. Since the lung margin never descends as far as the pleural margin, this recess is the preferred site for clinical procedures like thoracentesis.
Draining fluid from the chest.
Exactly, draining a pleural effusion. By targeting the recess, usually below the level of the ninth rib in the mid-axillary line, the clinician can reliably draw fluid without puncturing the lung itself, provided the patient isn't taking a maximal deep breath at that exact moment.
So the pleura forms the lateral boundaries of the central command area, the mediastinum. This centralized region is truly the anatomical heart of the thorax.
It is the nexus. The mediastinum is the central compartment of the thoracic cavity, located between the two pleural sacs, and it extends from the sternum to the vertebrae and from the superior aperture all the way down to the diaphragm. It is structurally dense and absolutely vital.
And once again, we return to our central anatomical landmark for its internal organization, the sternal angle and that T4-T5 plane.
It is the single most important organizing concept we have for this region. That imaginary horizontal line passing through the sternal angle at the T4-T5 vertebral level is the Great Divide. It cuts the entire structure into two primary parts. The large superior mediastinum, which sits above that plane, and is primarily a passageway for structures entering or leaving the thorax. And then the massive inferior mediastinum below the plane, which is where the main organs actually reside.
And the inferior mediastinum is further subdivided into three areas, relative to the heart's container.
We use the pericardium, the tough fibrous sac around the heart, as our internal reference marker.
So it's all about where you are in relation to the heart.
Exactly. The middle mediastinum is the central part, which contains the pericardium, the heart, the roots of the great vessels, and the main bronchi. The anterior mediastinum is the smallest subdivision, located anterior to the pericardium, between it and the sternum.
What's in there?
In adults, often very little, mostly fat, connective tissue, and sometimes remnants of the thymus gland from childhood. Yeah. And then there's the posterior mediastinum, which is the long vertical space situated posterior to the pericardium, lying anterior to the T5 through T12 vertebrae.
Why does this compartmentalization matter so much beyond just academic classification?
Understanding these compartments is absolutely crucial for imaging and clinical diagnosis. Pathologies are often localized to a specific mediastinal region, and that localization immediately narrows down your differential diagnosis.
Could you give an example?
Sure. A mass in the anterior mediastinum often points toward issues related to the thyroid, the thymocythymoma, or lymph nodes. A lymphoma. We call it the terrible T's.
Okay.
But a mass in the posterior mediastinum, lying close to the vertebral column and esophagus, is much more likely to be an esophageal tumor or a neurogenic tumor originating from the sympathetic chain. This spatial organization dictates both diagnosis and the surgical approach.
Let's give our listener a quick refresher on the most vital contents packed into the mediastinum.
Well, you have these crucial vertical pathways running through all the divisions. In the superior mediastinum, you have the aortic arch, the trachea, the esophagus, the brachiocephalic veins, and the critical vagus and phrenic nerves descending.
Oh, a lot of traffic.
A huge amount. And in the inferior mediastinum, you have the heart in the middle compartment, the descending aorta, and the azygos venous system running in the posterior compartment, and the continuation of the esophagus and the important lymphatic networks throughout. It is the central conduit connecting nearly every part of the body.
If the thorax is the central command post, then the vascular system is its major highway, delivering oxygen and nutrients to the walls that protect it. Let's start with the arterial supply that feeds the chest wall itself.
The general principle for the chest wall, musculature, and the skin is that it receives a highly segmented and very rich blood supply. It comes from direct cutaneous vessels and musculocutaneous perforators. This redundancy is essential for healing and physical function.
Where do these main arteries originate? We established 3 major sources that feed the thoracic wall, not just the organs inside.
That's right. Firstly, the primary source for the posterior chest wall is the thoracic aorta. As it descends along the vertebrae, it gives rise to the posterior intercostal arteries, which supply the lower 9 intercostal spaces, so spaces 3 through 11. They wrap around the back and side of the cage.
Okay, so that's the back. What about the front?
Secondly, the supply to the anterior chest wall, especially the upper 6 spaces, comes from the internal thoracic artery. This is a branch of the subclavian artery that runs vertically down the inside of the anterior thoracic wall, just lateral to the sternum, and it gives off the anterior intercostal arteries.
And the third source?
Thirdly, the superior lateral part of the chest wall gets blood from the axillary artery via branches like the supreme and lateral thoracic arteries. This links the supply system of the chest wall to the arm.
So we have these segmented vessels running horizontally along the ribs, the intercostal arteries, which are incredibly important for safety protocols in medicine. Let's discuss the classic anatomical arrangement that defines safety in this region.
This is the definitive anatomical detail for any clinical learner. It's the neurovascular bundle. The intercostal arteries, veins, and nerves following the vein, artery, nerve, van order from superior to inferior run together in the costal groove.
The costal groove.
It's a slight indentation located on the protected inferior border of the rib above it.
Why is that order and location so important, especially for someone performing a procedure like putting in a chest tube?
Because that placement offers maximum protection from routine trauma, but it dictates the absolute safety margin required during clinical procedures. Since the entire van bundle runs right on the underside of the superior rib, the only safe zone to insert a needle or an instrument is directly superior to the rib margin below.
Go over the rib.
Always go over the rib below. That's where you are least likely to hit the major nerve, artery, or vein. Failure to adhere to that rule risks causing a hemothorax bleeding into the chest or damaging the intercostal nerve, which can lead to chronic, debilitating pain.
Now let's look at the return route, venous drainage. The veins mirror the arteries, but the venous system has that fascinating critical backup network that we need to detail.
It does. Posteriorly, the posterior intercostal veins and their collateral branches drain primarily into a massive, robust system running adjacent to the vertebral column. This is the azygos system.
The azygos system.
It includes the main azygos vein on the right and the hemiazygos and accessory hemiazygos veins on the left.
And anteriorly, does it just follow the arteries again?
Yes. The anterior intercostal veins drain to the internal thoracic veins, which correspond to the internal thoracic artery. For the uppermost regions, the veins from the upper 1 or 2 intercostal spaces drain directly or indirectly into the large brachiocephalic veins in the neck.
Let's focus on the azygos system's significance. It's more than just a vein. It's the body's major collateral pathway for the trunk.
It's a remarkable piece of vascular engineering. The azygos system runs vertically alongside the vertebral column, and it connects the superior and inferior vena cava systems. It offers a crucial collateral route for venous return from the thoracic and abdominal walls directly into the superior vena cava, SVC.
Why is that backup necessary?
Imagine a serious medical event like thrombosis, a blood clot, or tumor, say a lung tumor, or a mediastinal lymphoma that's compressing or obstructing the superior vena cava.
That's called SVC syndrome.
SVC syndrome, exactly. If the SVC is blocked, the primary drainage pathway for the head, neck, and upper limbs is compromised. The azygosystem, which also communicates with the inferior vena cava, can dilate dramatically to take over the drainage of the thoracic and abdominal walls.
So it provides a detour.
A critical detour. It ensures deoxygenated blood can still return to the heart, albeit via a circuitous and often high-pressure route. This collateral function is a lifesaver.
Moving on to lymphatic drainage, the system is vital, particularly when we discuss pathology originating in the breast.
The lymphatic drainage network is multi-layered. We can classify it into superficial and deep systems. The superficial lymphatics, which drain the skin, follow the veins and drain primarily to the axillary nodes in the armpit region and the supraclavicular nodes just above the clavicle.
And the deep system.
The deep lymphatics follow the arteries and drain into deeper regional nodes like the peristernal, intercostal, and diaphragmatic nodes.
The source material focuses heavily on the drainage of the breast due to the implications for metastatic breast cancer, which is a major clinical application of this anatomy.
This specific network is of paramount importance because the route of metastasis for breast cancer often follows the lymphatic pathway. The cancer cells travel through these vessels.
So where does most of it go?
Lymph from the breast tissue drains overwhelmingly, we're talking 75% or more, to the axillary nodes. This is why the axillary nodes are so rigorously sampled in cancer surgery via procedures like a sentinel lymph node biopsy.
But relying on just the axillary nodes can sometimes miss metastasis, right? We need to consider the alternative routes.
Absolutely. This is critically important. The remaining lymph drains via other critical alternative routes. These include the peristernal nodes.
Where are they?
They run vertically alongside the internal thoracic artery near the sternum. And sometimes lymph can also go to the clavicular nodes. If a tumor is located medially or inferiorly in the breast, that peristernal drainage becomes the clinically most significant alternative route.
And that changes the treatment plan.
It can completely change it. It often requires targeted radiation or surgical dissection along that internal thoracic artery chain, as these nodes can directly cross the midline to the other breast or drain into the deep mediastinal chain.
And for the internal organs, the viscera, where does their lymph go?
Lymph from the thoracic viscera, the lungs, heart, esophagus, drains mainly into the various deep mediastinal nodes, like the tracheobronchial nodes around the carina and the bronchopulmonary nodes at the lung hilum.
And
From there, the lymph flows into collecting trunks, and ultimately it collects into the largest lymph vessel in the body, the thoracic duct. This duct then ascends through the thorax, exits the superior aperture, and drains back into the venous system in the neck, typically at the junction of the left internal jugular and subclavian veins.
Next, we navigate the nervous system, the incredibly complex wiring that controls both the voluntary or somatic movement of the chest wall and the involuntary autonomic function of the organs. Let's start with the somatic control, so sensation and muscle movement.
The thoracic wall is supplied segmentally by the 12 pairs of thoracic spinal nerves. The ventral rami of the first 11 pairs, T1, T11, exit the intervertebral foramina and form the intercostal nerves.
And they provide this beautiful specific segmental distribution.
A perfect segmental distribution to the chest wall musculature and the overlying skin. It's a very clear dermatomal map.
This segmental nature is why pain can be traced so precisely to a specific rib level. And these nerves run in that famous protected groove we mentioned earlier with the vessels.
Precisely. The intercostal nerves follow the same path as the vessels, running in the costal spaces between the middle layer, the internal intercostal, and the innermost layer of intercostal muscles, and they're inferior to the artery and vein.
Which makes them crucial targets for anesthesia, but also vulnerable.
Vulnerable to injury from something like a rib fracture, yes.
Let's elaborate on those crucial variations you mentioned in the T-spinal nerves, particularly the functional links they provide to other parts of the body. They don't all just stay in the chest wall.
No, they don't. There are 3 critical functional variations. First, the T1 ventral ramus is highly significant because the majority of its fibers do not stay in the chest. They contribute strongly to the formation of the brachial plexus,
Which supplies the entire upper limb.
the entire arm and hand. T1 provides much of the critical innervation to the intrinsic muscles of the hand, which is why a T1 nerve root injury can cause hand weakness.
Okay, that's T1. What about the lower ones?
Second, the rami of T7 through T11 don't terminate at the costal margin. They extend inferiorly, passing deep to the costal cartilages to supply the rectus abdominis and other abdominal wall muscles and the overlying skin. These are called the thoraco-abdominal nerves.
And what does that T7-T11 connection mean for diagnosing pain?
It means that irritation of a lower intercostal nerve, maybe T8 or T9, due to something like shingles or nerve compression from a herniated disc. Actually, in the thoracic spine or chest wall, it's a classic example of referred pain. And finally, the nerve inferior to the 12th rib, T12, is uniquely termed the subcostal nerve, and it supplies the lower abdominal wall muscles and skin of the gluteal region.
This is where that anatomical precision translates directly into pain management. The segmental nature of these intercostal nerves makes them ideal targets for regional anesthesia.
Absolutely.
Could you explain that clinical application a bit more for our listener?
Of course. Intercostal nerve blocks specifically target these nerves, usually near the angle of the ribs where they are most superficial, to provide dense local anesthesia for chest wall procedures.
Like what?
Like managing the extreme pain of multiple rib fractures or inserting a chest tube. Knowing the exact path and location of that Van bundle is the difference between a successful, safe procedure and a major complication.
Shifting gears, let's discuss the involuntary control system, the autonomic nervous system. This manages heart rate, lung diameter, vessel tone, all without conscious thought.
The autonomic system in the thorax is incredibly complex. It consists of the left and right sympathetic trunks and the parasympathetic input from the vagus nerves, and it all culminates in these interwoven neural structures called plexuses.
Focusing first on the sympathetic trunks, where are they located and what is their functional origin?
The sympathetic trunks are essentially vertical chains of ganglia clusters of nerve cell bodies running on either side of the vertebral column. Typically, there are 11 pairs of ganglia in the thorax, but they're often fused. Yes, for example, the T1 ganglion often fuses with the inferior cervical ganglion to form the stellate ganglion. The key to understanding them is that the preganglionic input for the entire sympathetic system originates exclusively in the spinal cord, from T1 down to L2.
So how does that system manage the thorax and the structures above it, like the head and the heart?
The preganglionic fibers destined for the head, neck, and upper thorax enter the sympathetic trunk at levels T1, T5. Once they're there, instead of synapsing at that level, they travel superiorly or inferiorly within the trunk before synapsing in a higher ganglion, like the stellate or superior cervical ganglion.
And then the signal goes out from there.
Then the postsynaptic fibers travel to supply the target organs, including the pupil, the sweat glands, and the heart, via the dedicated cardiac nerves.
You mentioned the T1 ganglion is incredibly important. Why is it such a classic point of clinical reference?
Because of its link to the structures of the head and eye. Damage to the sympathetic pathway, especially affecting the T1 ganglion, or the fibers passing through it, results in the well-known clinical constellation known as Horner syndrome.
Horner syndrome.
This interrupts the sympathetic supply to the structures of the head and manifests as the classic triad of symptoms. The ptosis, which is a droopy upper eyelid.
Okay.
Meiosis, which is a constricted pupil due to the lack of sympathetic dilation. And anhidrosis, which is a lack of sweating on the affected side of the face.
What about the lower part of the sympathetic trunk? How does that control the distant abdominal viscera?
The lower part of the trunk gives rise to the thoracic splanchnic nerves, the greater, from T5, T9, the lesser T10, T11, and the least T12.
And what's special about them?
Crucially, these nerves are preganglionic fibers that simply pass through the sympathetic trunk without synapsing there. They then pierce the diaphragm and descend into the abdomen to synapse in specialized pre-aortic ganglia.
And from there, they control the gut.
They control the visceral function of the abdominal organs, such as slowing peristalsis or causing vasoconstriction in the digestive system. It's the fight or flight response for your abdomen.
Moving to the counterbalance, we have the vagus nerves, cranial nerve X, providing the parasympathetic rest and digest control.
The vagus nerves carry preganglionic parasympathetic axons that originate high up in the medulla oblongata in the brainstem. They travel down the neck, bundled with the major vessels, and enter the thorax via the superior aperture, descending alongside the trachea and esophagus.
And once they are inside the chest, they form these incredible complex networks around the heart and lungs.
They do. They contribute heavily to the formation of the cardiac, pulmonary, and esophageal plexuses. Their primary function within the thorax is the involuntary control over smooth muscle contraction and glandular secretion. This means they mediate processes like bronchoconstriction, narrowing the airways, and slowing the heart rate. They work in opposition to the sympathetic system, ensuring a fine-tuned dynamic modulation of cardiopulmonary function.
So the cardiac and pulmonary plexuses are truly integrated systems, not simply two separate parallel pathways.
They are completely interwoven neural networks. You find them deep to the aortic arch and at the hilum of the lung, respectively. They integrate both the sympathetic input, which increases heart rate and causes bronchodilation.
And the parasympathetic input, which does the opposite.
Exactly. The outcome is a constant, localized negotiation, managing the demands of the body. For instance, when you run, the sympathetic system overrides the vagus nerve to raise your heart rate. When you rest, the vagus influence reasserts itself to bring it back down.
We've established the internal workings, but for clinical application, whether it's listening to the heart, placing a chest tube, or interpreting a chest X-ray, it all comes down to finding these structures from the outside. Surface anatomy underpins nearly every physical examination.
It absolutely does. Surface anatomy helps clinicians translate external two-dimensional findings, a point of pain, an area of dullness to percussion, or the preferred location for a needle insertion, to the internal three-dimensional arrangement of structures that we just spent an hour mapping out.
Let's review those absolutely indispensable skeletal landmarks. What features do we look for to start orienting ourselves on the surface?
Superiorly, the clavicles and the deep depression between them, known as the suprasternal notch or jugular notch, are easily palpable. Moving down the sternum, the sternal angle is our critical palpable ridge.
Which we've hammered home corresponds internally to the T4-T5 vertebral level.
We have, for good reason. Further down, the xiphisternal joint marks the inferior attachment of the sternal body and typically correlates with the T9-T10 vertebral level.
And posteriorly, how do we use the vertebrae for reliable orientation?
We teach students to start high. The C7 vertebra is usually the most prominent vertebral spine when the head is flexed. It's known as the vertebral prominence, though sometimes T1 is equally prominent. Then we use the spinous processes of other vertebrae as crucial anchors. For example, the T3 spinous process typically aligns horizontally with the spine of the scapula. T6 is a good mid-thoracic orientation point, and T12 marks the definitive transition to the more mobile lumbar region.
This brings us to the core dilemma in anatomy, and what our deep dive sources really highlighted in their research data. The most challenging part of anatomy is knowing that the internal landscape isn't static.
No.
The textbook maps provide averages, but they also emphasize the profound variability of where structures lie relative to these fixed skeletal landmarks.
This is the absolute key insight that separates textbook knowledge from clinical critical thinking. The number you memorize T4 is just a statistical average. It is not the guaranteed reality for every single patient you see.
Right.
Let's look at the data provided in our sources regarding intrathoracic viscera projection. It demonstrates this variability factor perfectly.
Let's start with the trachea and its bifurcation, the carina. Where is it supposed to be, and what is the real-world range?
The classic textbook average level for the tracheal bifurcation is the inferior border of the T4 vertebra, or the plane of the sternal angle.
The T4-T5 plane.
Exactly. However, extensive cadaveric and imaging studies reveal a surprisingly wide range in the population. The level can range from T3 all the way down to T7.
T3 to T7, that's 5 vertebral segments of potential variation. That's a huge margin of error if you're performing a bronchoscopy and expecting the carina to be right at T4.
It profoundly impacts procedures. Furthermore, one study specifically noted a measurable sex difference. The bifurcation was more commonly found at T3 in females compared to T4 or T5 in males, likely related to differences in thoracic height or lung volume.
So you can't rely on one number.
Relying solely on T4 is inaccurate in a large percentage of the population. It necessitates using imaging or flexible scopes for true precision.
Let's move to the aortic arch zenith, the highest point of that great vessel loop.
The aortic arch generally begins near the upper half of T4, and its zenith usually peaks around the T3 or T4 vertebra, just below the superior aperture.
But again, I assume there's variation.
Enormous variation. It's reported to range from the T2 vertebra, which is very high, all the way down to the T7 vertebra, which is very low.
What causes that variability?
The arch's height and position are highly influenced by factors like age. As the aorta elongates and uncoils with age, it tends to drop, and also posture, and even the phase of respiration. This just reinforces the principle that the T4 plane is a convenient academic divider, but the great vessels are dynamic structures.
What about the azygos vein arch, our essential collateral pathway?
The azygous vein arches superiorly over the root of the right lung, superior to the right main bronchus, before it drains into the superior vena cava. While it's often cited in the T4-T5 range, the documented range in our sources spans from T4 all the way down to T8.
So it's the same story.
It's the same consistent finding that multiple major structures, the trachea, the aorta, the azygos, the pulmonary trunk, all fluctuate widely around that sternal angle plane. This is arguably the most crucial takeaway for any learner of anatomy. The map is not the territory.
Now let's map the key respiratory structures onto the surface. The lungs and the pleurae. Where does the lung start superiorly?
The apex of the lung extends superiorly, projecting about 2 to 3 centimeters above the medial 1/3 of the clavicle into the root of the neck.
So it's actually in the neck.
A part of it is, yes. Anteriorly, the border of the right lung is fairly straight, following the sternum. The left lung, however, has a deep medial indentation called the cardiac notch.
And that's to make room for the heart.
It accommodates the heart and pericardium, and it exposes the pericardium directly to the anterior chest wall in that spot.
And locating the fissures is vital for determining where fluid or disease might collect in the different lobes.
It is. The major oblique fissure, which divides the superior and inferior lobes of both lungs, often aligns with a line extending from the T2 spinous process posteriorly, curving around the rib cage to meet the 6th costal cartilage anteriorly.
And the right lung has an extra one.
The right lung also has the horizontal fissure, which runs roughly horizontally along the 4th costal cartilage from the oblique fissure forward.
Let's clearly differentiate the lung margin itself from the pleural reflections, the boundaries of the potential cavity.
This is a critical distinction. The pleural reflections define the maximum extent of the pleural cavity, and they are distinct from the lung margins. The costal reflection defines the lowest boundary of the pleural cavity. It's the line where the parietal pleura reflects off the ribs and onto the diaphragm.
And where's that lowest margin?
It's defined by 3 key landmarks. It crosses the 8th rib at the midclavicular line, the 10th rib at the midaxillary line, and it reaches the T12 vertebra posteriorly.
That means the lung margin always stops 2 rib spaces superior to the pleural margin.
Exactly. The lung margin itself only extends down to the 6th rib in the midclavicular line, the 8th rib in the midaxillary line, and the T10 vertebra posteriorly.
And that 2 rib space difference.
That 2 rib space difference between the lower lung margin and the lowest pleural reflection is the clinically crucial custodiophragmatic recess we discussed earlier. It is that safe zone for sampling pleural fluid or administering regional anesthesia.
Finally, let's quickly locate the projection of the heart and the breast. The heart's ciliate is described as fitting within a trapezoid area.
The most clinically relevant point is the apex of the heart. This is where the pulse is maximally felt and heard, the point of maximal impulse.
Then where do we find that?
It's typically located in the left 5th intercostal space, roughly 8 to 9 centimeters lateral to the midsternal line. This is a critical point for any physical examination of the heart.
And the 4 cardiac valves, the aortic, pulmonary, tricuspid, and mitral, also have specific anatomical projections, though where we listen for them is often different.
That's correct. The 4 valves project anatomically onto the sternum and the adjacent costal cartilages, clustering around that sternal angle. However, the surface auscultation sites, the spots where you listen with a stethoscope for the heart sounds, are usually located away from the anatomical projection sites.
Why is that?
It's because we listen for where the sounds are best conducted and isolated as they radiate through the chest wall. For example, the aortic valve sound is loudest not over the valve, but up at the right 2nd intercostal space.
And finally, the female breast, a significant surface structure that exhibits that same wide anatomical variability we've seen everywhere else.
It does. The glandular and supportive tissue of the breast is primarily situated between the 2nd and 6th ribs, and it extends from the sternal margin medially all the way to the mid-axillary line laterally.
And the nipple position.
The position of the nipple is highly variable. It's influenced heavily by age, paradiso, childbirth history, and body habitus. While it's often positioned over the 4th intercostal space or the 5th rib in younger women, it's typically located significantly lower in multiparous and older females. It just reinforces that no anatomical landmark is truly static.
We've navigated the entire thoracic architecture, starting with the musculoskeletal framework and its mechanics, the pump handle and bucket handle movements. We then dove into the internal compartmentalization of the mediastinum using that T4-T5 plane.
Our favorite landmark.
Our favorite landmark, yes. And we mapped out the incredibly complex, often redundant nervous and vascular supply systems that make this area the body's central highway, complete with critical collateral routes like the azygos system.
If we connect this detailed anatomy to the bigger picture, the key insight that we absolutely must take away is the necessity of acknowledging anatomical variability.
It's the central theme.
It is. The textbook numbers T4, T5, fifth intercostal space are merely mathematical averages derived from populations. Clinical practice demands recognition that while the average level for the tracheal bifurcation is T4, the actual level in an individual patient might be T7 due to structural differences or their position on the table.
And that awareness is crucial.
It is crucial for accurate diagnostics, for proper interpretation of imaging, and most importantly, for safe procedural interventions that rely on precise landmark identification.
We've seen how the sternal angle at T4, T5 is the central dividing line for the entire thorax. Think about this. We've established that the great vessels and visceral structures fluctuate vertically in relation to the vertebrae. What physical changes, from severe kyphosis, that hunching of the spine, or rapid weight loss, or massive cardiac enlargement, cardiomegaly, could shift the position of this critical transverse T4, T5 plane relative to the actual internal viscera?
That's a fascinating question.
It raises the profound question of how fundamentally altering the superior border of the mediastinum changes the spatial relationship of the great vessels and trachea. It leaves you with a deep appreciation for just how dynamic and adaptable our internal structures truly are under the stresses of life.